Hello and welcome to the iMedX Best of Day series here at our annual hematology meeting in San Diego, California. My name is Dr. Joseph McHale. I'm a hematologist at Mayo Clinic in Arizona. I have the privilege of being the chair of this series, and today welcoming a very good friend and expert in multiple myeloma, Dr. Saad Usmani. Saad, great to have you with us today.
Thanks, Joe.
So Saad, this has been a banner year and a half or perhaps 2 years in multiple myeloma. We've seen 4 new drugs approved within 1 year. We've just had more FDA approvals in the last couple of weeks, new molecules, new strategies. You and I could do this all day, but we're only going to take about 15 to 20 minutes to do this. But why don't we chat a little bit together about the spectrum of myeloma. As our clinicians listening know, we still put people in the 3 big categories of MGUS, smoldering myeloma, and active myeloma. Historically only treated active myeloma. But I know that there's been some excellent work presented here in smoldering myeloma. Can you tell me a little bit about that?
Absolutely, Joe. I think you're right. I mean, that spectrum is changing, and it was primarily driven by the accredited study that was published in the New England Journal of Medicine a couple of years back by the Spanish myeloma group. Even though it was small in scale, but the study showed that patients with high-risk smoldering myeloma may benefit from therapy. And in that vein, Dr. Irene Gabriel has presented some early data with her phase 2 experience using the elotuzumab Lendex combination in high-risk smoldering myeloma patients. In the grand scheme of things, I think we're getting to a point where we will have an answer in a couple of years whether to treat versus observe. We have the large ECOG trial that Sagalonial is leading with an ECOG to answer that question. The next step is how best to treat them. So I think this is probably the first in several series of studies that we're going to see in the future.
And so for our treating clinicians now, I guess the take-home message to some degree is, we've redefined myeloma to add 3 features that used to be in the smoldering bucket are now in the active bucket, the greater than 60% plasma cells, light chains involved over uninvolved of greater than 100, and MRI greater than 1 focal lesion on MRI. But I guess, are you saying right now we're still not treating anything below that, as it were? We're not treating smoldering myeloma. We're doing this just on an experimental basis, but in the future we might?
Agreed. So that's exactly what I'm saying. I think from a clinician's perspective, it's still very important to follow those patients very carefully. Watch out for the slim crab criteria, and that would prompt you to treat. But if you are close to a myeloma center that has clinical trials for high-risk myeloma, smoldering myeloma patients, then it would be appropriate to make those kind of referrals, because pretty soon, I think in my mind, we will be left with an MGUS-like definition versus folks that we really need to treat. I think that spectrum will change over the next 5 to 10 years in that vein.
So maybe even move that line a little bit further down, as it were. Because sadly, I guess we still see smoldering patients, even under our watch, who end up breaking a bone or having renal dysfunction to catch them. On the other hand, I think there has to be a caution to our audience that we also don't want to overtreat. Someone said to me the other day, does this mean we're going to be treating all MGUS patients? Well, we're going to be treating 5% of the adult population. Would be way overkill to do that.
I absolutely agree. We do recognize that there are patients who may have smoldering myeloma who never progress. There are patients who go years and years without declaring themselves. So it's clear we need to distinguish the true patients who are going to have end organ damage versus not. So I completely agree with you. The needle will move, but I think we have to be cognizant of the fact not to treat the ones who don't need it.
Okay, great. So right now we'll keep that needle at the slim crab, as you've called it.
Absolutely.
Well, there's some upfront trials of significance. One of the trends here in the U.S., of course, the general standard of care upfront has been bortezomib, lenalidomide, dex, or sometimes called VRD or RVD. But I understand there was some good work looking at introducing carfilzomib earlier on. Can you comment on that?
Sure. So for the transplant eligible patients, Todd Zimmerman and Andreas Jakubowiak from the University of Chicago have been doing a study using KRD as an induction and post-transplant consolidation, followed by a maintenance strategy using these three therapies, showing unprecedented depth of response for that group of patients. Almost everyone going into a VGPR or better, and then patients who are getting to CR appear to be MRD negative. And this is the same early result that they had shown a year ago, and now we're seeing that with passage of time, a greater number of patients are going into improved depth of response. Their safety signal did not reveal anything that we already don't know about carfilzomib or this combination from previous phase 1-2 studies. However, I do want to mention the French trial as well. So Dr. Roussel presented a very similar study in the French patient population, where although they see wonderful depth of response, kind of validating the observation made by the US colleagues, but they are seeing a small cardiac toxicity signal in a subset of patients. Now, that could be just a statistical glitch because it's only a 40 subject study, but it hasn't really been observed to the same magnitude in at least 3 different US trials. So we'll have to see how that plays out.
So for the practicing clinician, I know this is a question I get often in the community. Do I ever use KRD up front? If we think of RVD as being generally standard of care, are there patients tomorrow, Saad, that you would in clinic, off clinical trial of course, give KRD to?
So yes, I think the 2 categories of patients who may benefit from carfilzomib instead of bortezomib as the proteasome inhibitor of choice in the upfront strategy are the ones who are already suffering from neuropathy.
Either from diabetes or the disease itself, maybe?
Absolutely. So those patients may benefit from getting KRD in the upfront setting. The other class of patients may be the high-risk patients, specifically the translocation 414s or 1q21 amplifications above 4 copies. But we have anecdotal data in experiences where these high-risk patients do benefit from a KRD-based regimen. We see the same pattern in the Zimmerman experience as well as in the French experience, that high-risk patients are benefiting from this induction regimen. So those are the ones where I would consider KRD as the induction regimen of choice.
And I think that's very insightful and very helpful, because it sounds like you haven't done the full shift over, but you've definitely used it in that subset of patients. I think that reflects what's happening. I know that the NCCN has listed carfilzomib as a reasonable choice up front, although they don't have a formal FDA designation in that right. But I agree with you, in that highest risk population, that could very much be a legitimate choice. What of those patients who are not going to autologous stem cell transplant, which I know there are other studies that you and I have discussed before that seem to continue to validate, and we haven't time to talk about it today, but continue to validate the role of transplant in eligible patients. But let's say you have a patient that is not going on to transplant. The first trial, which was primarily focusing on long-term versus shorter-term lenalidomide, also had a MPT arm that we know is not traditionally used here in the U.S., was updated at this meeting. Any thoughts about that? Is RD still what we should be using in older patients?
I believe so. This current update showed longer follow-up to tease out if the PFS benefit is holding in the RD continuous therapy arm, and that's exactly what we're seeing. Interestingly, due to Vincent Rajkumar's ECOG trial, there had already been a shift away from non-melphalan-based regimens in the United States. So it's a good validation of what we felt was the right thing to do for that patient subgroup. RD is the appropriate choice for transplant ineligible patients, especially the ones who are intermediate to frail.
If you had a high-risk patient not eligible for transplant tomorrow, would you also generally go to RD, or would you add a proteasome inhibitor to it?
So the preference would be to add a proteasome inhibitor to those patients, but in real life, what we try to do is, generally we're doing an eyeball test for frailty rather than more objective assessments, and using more dose attenuated regimens that include bortezomib. These, the RVD light
Right.
regimen that Nupur Raje came up with, which isn't being presented at this meeting, but perhaps is a practical solution for those patients.
Okay, great. The other area, of course, that's been just absolutely massive in myeloma over the last little while, and
Oh
you've
my
been
gosh,
centerpiece to
yes.
this, has been immunotherapy. The introduction of daratumumab as a single agent, but the updates that we've had even since this meeting last year with combining it with lenalidomide or bortezomib, the Pollux and Castor studies. I know they were being presented here as updates. Can you give us the synopsis of those?
Sure. I mean, these are two extremely striking clinical studies which are changing the way that we're going to be treating myeloma patients. Both the Castor and Pollux trials can be considered sister studies because they're essentially examining a fairly similar patient population of 1 to 3 prior lines of therapy relapsed myeloma. In one of the studies, the combination of daratumumab, Lendex is being compared with Lendex, and that's the Pollux trial. In the Castor study, it's daratumumab being combined with bortezomib dex, compared with bortezomib dex as the standard of care arm. The difference between the two studies is that in the Castor trial, bortezomib dex is given for only 8 cycles on both arms, and dara is continued in the experimental arm, whereas in the Pollux study, both the arms have continuous therapy until relapse and progression. So the updates at ASH, I think Pollux has a 17-month follow-up, which is several months more than what the previous data had been reported, and I think the updated follow-up, median follow-up on Castor is about 12 months. So we could continue to see ongoing improvement in depth of response. The median PFS hasn't been reached, regardless of whether you look at prior lines of therapy, prior drug exposure, or high and standard risk cytogenetics. So I think that's quite an important observation, especially in light of the high-risk features, because immunotherapies appear to be more agnostic to the pathway-driven mechanisms inside the cancer cell, and they're really trying to harness more immunomodulatory effects. And that's where I feel perhaps that the DRD regimen may make more sense.
And of course, this is huge now, right? As the audience may know, this just led just a couple of weeks ago to the FDA approving both of those regimens, daratumumab Lendex and daratumumab bortezomib dex, in that 1 to 3 prior line population. So it sounds like we're going to be using a lot more daratumumab in the near future. And on that vein, I know that there's some guy named Sadhu Smani who's presenting a paper that one of the challenges we've had with daratumumab has been the length of that infusion, especially that first one. I know some of our community providers actually split it over 2 days because it takes 8 to 9 hours. But you're presenting some great work at a subcutaneous infusion of this. Can you give us a little bit, as the principal investigator here, can you tell us a little bit about this?
Sure. So this, I agree with you. When we were developing daratumumab in the phase 1, phase 2 setting, this is something that we did encounter, the long infusion times. The current phase 1b that I'm going to be presenting, it's called the PAVO study, and it's a pretty neat technology. Daratumumab is being combined with a recombinant hyaluronidase enzyme, which has been developed by third party. But essentially, the concept is you give the drug as a more concentrated infusion under the skin. The enzyme breaks down the soft tissue and creates a reservoir of daratumumab that continues to give a drug release, just as you were getting it through the IV, if you will. The difference appears to be the Cmax. So the Cmax, just as you would expect with IV bortezomib versus sub-Q bortezomib, would be lower, but the C trough levels would be very
Very
similar.
smooth.
So
And how long is the actual subcutaneous infusion?
so the final dose that we chose was 1800 milligrams, and it's given over 30 minutes. It's a 90 ml infusion. I do have to say that a more concentrated formulation is being prepared for the expansion cohort.
Wow. So I mean, we've already gone from 7, 8, 9 hours down to half an hour, and you're saying it might even be shorter than that.
Yes.
So again, not quite ready for prime time, obviously, but definitely a hope in the minds of our listeners as this is perhaps one of the greatest challenges we've had. Can I ask, the other challenge, of course, with daratumumab has been the infusional reactions.
Yes.
How is this subcutaneous infusion? Is it producing infusional reactions, or how is it tolerated?
So in the expansion of the 1800 milligrams, in the 45 patients that have been treated so far, the infusion reaction rate is 20%, which, as you know, is much lower
Than the 50% pretty well that we saw in the trial.
And at the 1800 milligram dose, we have yet to see a single grade 3 infusion reaction. So I think this appears to be the formulation that may move forward fairly quickly.
Excellent.
We may still have to prove the point to make that IV versus sub-Q comparison.
Excellent. Well, time's going quick as always, Saad, but before we close off, looking ahead to the future, I know that there are so many drugs being developed in myeloma, but there seems to have been a lot of talk about two drugs here, selinexor and then the CAR-T approach. Can we just very quickly touch those? What's your gut feeling about what we've seen with selinexor?
I think selinexor is a very active drug. The fact that you're seeing 20% response rates in a very refractory, quad refractory, essentially patient
Or even
population.
penta-refractory in some, yeah.
I would agree. I mean, there are data refractory patients on that study with a median PFS of around 5 months, if I remember correctly. That's pretty stark. Kind of. It does open your mind. One of the issues that I am concerned with is the GI toxicity. Some of that GI toxicity may be mitigated by various combinations in the future. I think if we can figure out the GI toxicity issue, this is a very exciting agent.
Excellent. And then what of the CAR T-cell story in myeloma? Are we there yet?
We're not there yet, but we're getting there. I do believe that the technology is nascent. We're still trying to figure out what the best targets and constructs are, how to keep those CAR T cells alive, how to manage the toxicity, especially the cytokine release syndrome. But we've seen data with the CD19 and the BCMA constructs at ASH that there is activity. There's clear activity. Now, how do we harness that activity and keep it going? I think that's the key. The other issue that I think we're going to be faced with is how to keep those CAR T cells alive and kicking after the infusion. Can we reinfuse the CAR T cells? Because one thing that we are seeing, even in patients who are getting to a CR, once the CAR T cells are gone,
the disease wakes up again.
Response, yes.
Yeah. Okay. Well, great. So this has been fantastic. So we've talked about a lot of different things: potential greater use of carfilzomib up front, the continued use of lenalidomide dexamethasone, much earlier and more prolific use of immunotherapies, daratumumab in particular, and still more agents to come in the future. These are exciting times in myeloma. Thank you again for joining me.
Thanks, Joe.
And thank you very much for joining us in our Best of Day series here at IMEDX. We appreciate you taking the time to listen in to what has been happening here. Is an exciting meeting, and we look forward to having you join us in future activities. Thank you.